Welcome everyone to this Public Health Palliative Care Initiative Showcase. It's co-hosted by Public Health Palliative Care Australia and New Zealand Chapter and Palliative Care Queensland on what's the second official day of National Palliative Care Week, the theme of which is Palliative Care, It's More Than You Think. My name's Bruce Rumbold. I'm an Associate Professor in Public Health and Director of the Public Health Palliative Care Unit at La Trobe University, and I'm happy to be facilitating today's session. And I'd like to start by acknowledging, as I invite you also to acknowledge the traditional owners of the lands from which we meet. I'm on the Wurundjeri, the lands of the Wurundjeri people of the Kulin Nations down in Melbourne, and each of you, I guess, can rehearse the name of your traditional owners, and we acknowledge together their elders, past, present, and emerging. The co-hosts of today's seminar, as I've mentioned, are Public Health Palliative Care International and particularly the Australian New Zealand chapter of that organisation. And they believe that death, dying and loss and care is everyone's responsibility. Public health approach to end-of-life care views the community as an equal partner in the long and complex task of providing quality healthcare at end of life. Palliative Care Queensland is an independent, not-for-profit peak body representing the people who care for Queenslanders living with life-limiting conditions. Palliative Care Queensland's belief is that the way we care for our dying is a significant indicator of our society's values. Palliative Care Queensland's mission is quality care at the end of life for all Queenslanders. So before we launch in and introduce our various presenters, there's a couple of bits of housekeeping. First of all, I'm sure you'll be familiar with the fact that Zoom's got a chat feature, which enables you to interact with each other. Please, if possible, unless it's a particularly direct message, select the message for all panelists so that everybody can see your comment or your reflection as we go through the presentations. There's also, to make it a little bit more formal, there's a Q&A button to ask a question of the panel. And it's quite possible, I'd imagine, that as we see some of the chat ideas consolidating, they could become a question which goes to the panel for the session. There's a question and answer session at the end of the webinar. So we invite you then to think about that and perhaps submit questions, which we'll try to moderate and consolidate for discussion toward the end. Okay, so today we're going to hear about various initiatives that are happening across Australia in public health palliative care. And to start off, I provide a little bit of the background perhaps to the broader ideas of public health palliative care that started off actually at La Trobe University at the turn of the century and became exported globally, probably with Alan Kelleher, who was the founding director of the La Trobe unit and has since become a global ambassador, I guess one could say, in his various positions around the world. Right, for those of you who missed the introduction, if you did, I am now trying to sort out my PowerPoints, which is always an interesting strategy. I somehow have been successful in obtaining the screen belonging to PCQ. Oh no, I haven't. Is that all right? Excellent. For those who, if you missed the introduction, came on a little bit late, my name is Bruce Rumbold. I'm the Director of the Public Health Palliative Care Unit at La Trobe University. And what I want to talk to you today a little bit is about the ideas of how public health and palliative care might relate with each other. And I've called it a relationship still being negotiated. Part of the reason for that is the differing definitions or understandings of public health. And the World Health Organization talks about public health in this gloriously encompassing definition: the art and science of preventing disease, prolonging life, promoting health through the organized efforts of society, which you could almost summarize, I suppose, as public health is anything you want to get away with. Although the devil in the detail is the scope of organization. And in a sense, the organized efforts around public health vary almost along a continuum from the people who say public health is implemented through the healthcare services funded by the government. That is, public health is government services, through to the people who say that public health requires the contributions of every sector of society, so that the health of society has to do with its workplace relationships and its border requirements and its import-export stuff, etc., etc., etc. In other words, some of the elements which actually we have seen linked into public health through the pandemic. And when it comes to public health approaches to palliative care, the difference shows up, or this difference shows up, particularly around questions about integration. Is palliative care something which requires integration within the health services? That is, that end-of-life care happens when palliative care principles and practices are thoroughly integrated within the healthcare system? Or is public health palliative care require the engagement of the whole of the community?
Excuse me, Bruce. I'm sorry. We don't seem to have your slides on our screen.
Ah, thank you, John. In that case, I need to head back, if you'll excuse me a moment, and see how I go. I'll start again. This is always the trouble of a rehearsal. It actually gives you a false sense of security. Now, do we have something at this point, John?
Yes, that's great. Thank you. Just need to open your sorry, go back.
Make it play.
Yep, make it happen. Hooray.
Okay, apologies. Title slide, WHO definition. Questions about organization. And then my next point, in a sense, that this conversation between public health and palliative care has been going on really since the beginning of the movement. Palliative care began with hospice care, which is sort of a mid-20th century response to so-called death out of time, that is, people dying young of cancer. And it emerged, as you all familiar with, the ideas of Cicely Saunders' hospice care, which was holistic care, and in a sense was a community-based movement, because the initial hospice care systems emerged at the edges of the healthcare system, but fundamentally driven by community fundraisers, community organizers, community practitioners to a large degree. So it was, in that sense, a community-based or a community emergent organization. But perhaps 10 to 15 years after the community programs began to emerge, the questions of continuity, sustainability became pretty acute, and by and large, hospice decided they needed to join with the healthcare system, and hospice became mainstreamed as palliative care. So in a sense, this was the stage at which palliative care emerged as a public health, in the sense of government funded by and large healthcare movement. But it also, by joining with the health services, brought about some fundamental shifts. It moved from being grassroots movement to centrally funded services. It became much more conformed to the health system rather than being accountable to its local community. In the first instance, it became conformed to health system funding and reporting and evaluation, and clinical approaches by and large began to dominate the approaches to care, so that palliative care became a discipline which began to take on a hierarchy of specializations, and care became professionalized and individualized. Gross generalizations in a sense, but I think reasonably fair in terms of the shift. And it's not a matter of either or. Fundamentally, a public health approach is one which is going to take the broad view without rejecting in any sense the healthcare, palliative care, which is developed. So a public health approach sees dying as a social activity as well as a medical concern. So we have to pursue health in dying, maintaining and enhancing social connections, minimizing disruption, helping the dying people to maintain some sort of coherence in their experience. So if you like, the system of end-of-life care is one which embraces all these dimensions as demonstrated in this circles of care diagram. Or to put it in another way, in addition to providing healthcare services, we need to remember that where people are cared for is not the same as where people end up or end their lives. That people who are living with life-limiting illness spend a great deal of their time with their existing social networks rather than in relationship with healthcare practitioners. So the majority of their care is not this time is informal. That is, it has to do with their friends, neighbors, relatives, who, however, often feel unprepared when they find themselves coping with illness in that relationship with this other principal person. And so there's a sense in which we need as local communities to relearn the old ways of caring for one another. One other note that I guess I would want to make is that a public health approach is not the same as providing psychosocial care. That is, introducing a public health perspective isn't a demand that health services take on even more responsibility to suddenly start running community engagement programs, et cetera, but it's an invitation for health services, and in this case, palliative care services, to consider what aspects of a public health program they might provide, what they can facilitate, what they can encourage, and based upon their knowledge and the possibilities and problems in the final stages of life. So the core strategy of a public health approach is forming strategic partnerships, not necessarily in providing services. So how might we go about an organized effort in a public health approach to palliative care? Well, this is where the La Trobe University journey started out, I guess, with Alan Kelleher as Professor of Palliative Care, as a social scientist, and a unit that was basically composed of social scientists and pastoral care people. And Alan began during the first few years, took two core public health models and applied them to palliative care or end-of-life care: the Ottawa Charter and healthy settings. The Ottawa Charter applied to palliative care produced this model of health promoting palliative care, whereas the healthy settings approach produced compassionate cities. Ottawa Charter is a general argument that in order to promote health, we have to change systems through a number of interlocking strategies. We have to work at the level of policy and settings and communities and personal skills, and we need to reorient health services to reach out into the community, or to be open to the community, more than to be focused essentially on producing coherence within their own offerings. Perhaps one of the important things, or one of the most important things about the Ottawa Charter argument, is that if you want to bring about systemic change, you have to do all these things. And obviously no one individual or no one agency can do them all. It has to be change which is accomplished through partnerships between people, between agencies, between organizations, and across sectors. The other model, which was the healthy settings model, goes back to, in a sense, the original ideas of public health in the mid-19th century, that healthy settings are where health begins. So how do we ensure that healthy cities or healthy communities have safe physical environments, that they provide social inclusion and a place for all, that the community and its governance strategies are in creative dialogue, constructive dialogue with each other, that the community remembers appropriately, that health services are accessible to all, that there is the diversity is celebrated. This healthy settings model became the basis for what we talk about as a compassionate communities approach to end-of-life care, and we'll be hearing more about that in the presentations today. So to summarize it, in a sense, building capacity in communities is really a core issue for public health approach. We've done a lot of work on health services. We need to do more work on communities and the interface between communities and healthcare services. So the core capacity issue is around collaboration, both the capacity of informal caring networks in the community and the negotiating the relationship between the formal and informal care. And along with that, introduces to palliative care a key issue of public health, and that is inequalities, which continue to lead to the skewed provision of end-of-life care in our current system. There's a bit of PR. We've got various examples of that in the sorts of work that's done by the La Trobe University Public Health Palliative Care Unit, and you can find those on our website, along with some of the tools that are involved. But more importantly, today we're going to hear about several examples of initiatives which work within and across the circles of care. And I guess the invitation we have to you today is, as you listen to the presentations, think about your own circles of care in your own context. What are the possibilities? What are some of the barriers in your particular context? And how might you go about addressing them? Okay, well, I'd now like to introduce to you Dr. John Rosenberg. John is the president of the Public Health Palliative Care International Network, and he's a senior lecturer in the School of Nursing, Midwifery and Paramedicine at the University of the Sunshine Coast. And what John's going to do is to present on the global perspectives on public health palliative care, an update from the international community. Thank you, John.
Thank you, Bruce. Can I just check that everyone can see the global picture of public health palliative care? Yeah, got some nods. Thank you. Well, thank you very much, Bruce, for introducing the webinar this morning. It is, and to really lay the foundation of some of the history of public health palliative care. I guess the perspective that I want to bring as the president of an international association, but as an Australian, is to provide today just a bit of the global picture of what's happening with public health palliative care, so that the broader context of what's happening in Australia and in Queensland in National Palliative Care Week can be provided. So I shall see if I can advance my, interesting, let's have a look. Next, there we are, okay. So I guess one of the things to talk to you about first, and I'm just trying to get rid of the view of myself so that I can see the screen. Why wouldn't you? So who is Public Health Palliative Care International? So we're an organisation that was formed at one of our international conferences, and I can't quite recall the year, but it was in Limerick, in Ireland, and there was a recognition that to galvanise the perspectives of various practitioners in public health palliative care, and by practitioners I mean people who are at the coalface, communities, government representatives, service representatives, academics. So to galvanise that approach so that we could promote it in a cohesive manner. And I'm not going to read out our aims there, but they're in the screen in front of you, and you can see that there are some fundamental issues there around health promotion. And Bruce mentioned the Ottawa Charter and looking at health promoting palliative care. And so those 5 key action areas are fundamental elements, I guess, of what public health palliative care is about. We're also looking at supporting our members, and you know, if you want to talk about advertising, Bruce, then here's one. You can become a member of Public Health Palliative Care International. But our idea here is that we are assisting members and other interested parties to undertake educational and practice endeavours to further health promotion within palliative care. Now, every 2 years we have a conference, an international conference. Some of you may have attended or been aware of the conference that we held in the Blue Mountains. And in fact, it was 2 years ago, but of course we all know what happened after that. So I've got a little bit of information about how we are handling the every 2 years component of what we do. But the important thing about our conferences is that it's not simply, or it's not solely an environment for academics and researchers to come together and swap research stories. It's very much focused on practice wisdom. So yes, there are those of us who are conducting research in this area who participate in the conferences, but equally those who are practicing in compassionate communities, in policy reform, in community development, who also come together. And so it's a conference quite unlike some of the other more scientific conferences that you may have attended. We, of course, want to encourage and foster research and evaluation. In this, we have an opportunity to build the body of knowledge about the impact of conducting public health palliative care strategies. Bruce emphasised the professional links very strongly, and I couldn't agree more. The whole notion that this is a partnership between various parties is fundamental to what public health palliative care is. And when I undertook a doctoral study in health promoting palliative care, which I finished in 2007, and even still now there is confusion about, well, we're a busy palliative care service, how can we possibly do more? And I think the idea of partnership, of course, is one that is the answer to that question, is not to do more, but to do differently. We provide a global forum through our website and some other activities that I'll refer to. We have an early career researcher representative on our council, on our international council, and he represents part of the efforts of Public Health Palliative Care International to support students who are undertaking research in this area. And we have a number of doctoral, masters, and even undergraduate students who are being supported to to work in this area. And then we have a vested interest in collaborating with anyone who's active in this area. So that's what the intention, if you like, of the association is. And Bruce has already mentioned that these are the key action areas of health promotion in palliative care, as in the Ottawa Charter for Health Promotion, and as they apply to each of the different elements of palliative care. So in our Constitution and in all of our operations, the association's committed to pursuing these key action areas. So what's the global picture? Well, we've seen an unprecedented use of the word unprecedented. Of course, COVID changed everything for everyone pretty much, and it was no different for PHPCI. So some of our work that we've been doing has been around being a conduit of information for people who are having to handle the life with COVID when people are dying from it or are living and dying amongst it and not necessarily from it. I just want to point out a few things here which you see on the screen in front of you. The very beginning of the pandemic, a group of Italian authors, and you may or may not remember that at the very beginning of the pandemic, it was Italy which was one of the hotspots. And this group of Italian authors said this in an article that they published, that our health systems have been built around the idea of patient-centred care. But an epidemic, and of course we mean pandemic now, but requires a change of perspective towards a concept of community-centred care. And so this sits squarely in the court of public health palliative care. There is a global need for the exercise of compassion, for a public health approach, not only to the management of disease, but to supporting those who are impacted directly and indirectly by the situation we find ourselves in. We being the PHPCI Council, released a statement last year, and this list here of 5 points really, I guess, highlights our key messages. The public health has always been and continues to be about connections between people. And so the discussion that we've had so far about partnerships is really a reflection of that. We are not doing this alone, any of us, and so there's a need for compassion in our communities like never before. I don't know about you, but I live in a very long cul-de-sac on the north side of Brisbane. And we had a WhatsApp group formed almost immediately, and there was more communication in our street than ever before. You know, if you translate that very local picture into a national picture or even an international picture, then that communication between parties is so essential to our navigating of the pandemic. So if we believe that palliative care is everybody's business, then the social connection, mutual support, civic action are the cornerstones of what we do. And that reflects some of the models of public health palliative care that we use, where we see services, the corporate world, the civic world, communities, community groups and organisations, all working together to support those of us who are impacted by the pandemic, which is by definition all of us. So the task that Public Health Palliative Care International sees itself having at this time is to work with all of these different levels of our societies, families, neighbourhoods, hospitals, communities, and to really use the technology that's at our fingertips and other means so that we can travel this together with good effect. So the function of Public Health Palliative Care International really is to identify the national, regional and local innovations across those 5 areas of the health of the Ottawa Charter for Health Promotion. So there's policy and service provision in there, as well as community mobilisation and right down to the interpersonal connections that we have. And there are resources that that support the rollout of compassionate communities actions and others on our website, and there is a page there called COVID-19 resources. What we did was we put a call out globally and said, what are you doing in this pandemic? How can we put information about your national, regional or local action so that others can access it and perhaps apply it to their own situation. So that's the that's on the page there. In Australia, the Care Search, Palliative Care Australia and Palliative Care Queensland all provide information about COVID-19 and palliative care, and I think that going to any of those sites will provide you with information. PHPCI sees itself very much as the conduit of information, so that we can direct people to others who are working in ways that might be helpful to them. The other thing that's happened, and I noticed this particularly working in academia, is we've had an exponential increase in the number of peer-reviewed journal articles that are addressing palliative and end-of-life care issues within the context of COVID-19. So one of the things you may not know is that Public Health Palliative Care International has a peer-reviewed journal. It's called Palliative Care and Social Practice, and it has recently published. I'll just put my specs on. There was a public health research in palliative care seminar hosted out of Ireland, but part of an international research seminar by the European Association for Palliative Care. And our journal has published the abstracts from that event. And so many of them, of course, address COVID-19. And not just there, but across the board, there is a comprehensive academic discourse on what's happening in the world of palliative and end-of-life care when we're dealing with such a serious public health issue. So some of the challenges and opportunities that are coming.
John, we need to move on, I'm afraid, to stay with. But the slides will be sent out, and so remind you that this is one of the slides you really need to have a look at in terms of future directions.
Indeed.
Look, thank you, John.
No worries.
I'm rather aware that you've had 2 blokes pontificating about what to do. You are now about to have 4 women to tell you how to do it. The first of these is Jessie Williams, the CEO of the Groundswell project. Jessie will be talking about 2 place-based and 2 national programs at Groundswell. He's engaged in with health and community partners, and her presentation is entitled "One Foot in Health, One Foot in Community," illustrating obviously that tension between linking the formal and informal networks of care. Thanks, Jessie.
Thanks so much, Bruce. Thank you, John. Oh, that was a brutal cutoff, wasn't it? So
it was indeed.
I got to be on my game. Look, I think our sweet spot at Groundswell is the practice wisdom, you know, as John was saying. So I'm excited to bring you 4 initiatives. My goal here is to take everybody through them pretty quickly so that you can get in touch and learn more. So forgive me for speaking quickly. Look, the first one I want to talk about is in an area of New South Wales in the Illawarra Shoalhaven region, which is down south. It's on the coast. And it's the Illawarra Death Cafe network. So I'm going to describe it and then I'm going to share some lessons learned. The key objective for this project was to provide the community with a plan for a purposeful engagement with community members who are in need of compassionate support. So we were lucky enough to work with the health partner here to have a runway of 6 to 9 months of conversations before we actually decided what the action project was going to be. So our first community development worker had lots of cups of tea, and of course COVID hit, so there were lots of online conversations. And ultimately what the network decided to do was a Death Cafe facilitators network. So our role is to convene this network of facilitators. They are volunteers. They come from all walks of life. And to date, we have 6 facilitators. We've had around 110 members of the community attend a Death Cafe, and we've got about 200 people on that mailing list. So the lessons learned for us in this initiative is have a runway. You know, we don't parachute into communities at Groundswell. We always ask what's strong, what's there, what exists. And if we do get lucky enough to get some funding, we hire people from that local community. So fund the organising. The organising role, as we all know, is really tricky. There's a lot of work that goes into organising and convening. We know from our research from the National Compassionate Communities Forum that burnout was the key issue of community development work, especially unpaid community development work. So fund the organising. And lastly, the lesson here is, you know, grow the ownership, skill them up and let them fly. So decisions are made by the Death Cafe facilitators on what actions they want to take. And they are part of an action learning cycle, continuously asking, what do we do next? What do we do differently? Our next initiative here is in Queensland. So community connectors are found in all spaces and all walks of life. We've got community connectors in, you know, the disability space and the social housing space. It's very exciting to do community connectors in the end of life space. So, you know, we took inspiration and training from the Mendeep, let me get the words right, Health Connections Mendeep over in the UK. And essentially what we wanted to do here with our primary health network partner is to roll out a train the trainer model. So we've done train the trainers in Sunshine Coast. On Wednesday of this week, we're launching in Bundaberg. So we're doing Wide Bay and we're doing Central Queensland. So facilitators of the community connector model are coming from a broad range of backgrounds. We've got allied health workers, we've got end-of-life doulas, retirees, disability workers. The PHN in this initiative are really interested in learning about what role they can best play to support the sustainability of these individuals, of trainers, and also the groups that are now forming in each location. So, you know, with a finite amount of money, we spitballed, I guess, a whole bunch of ideas with the interagencies, and we all agreed that doing a train the trainer around the community connector model would be the best thing that we could do. And our lessons learned here are, again, work with the local assets. When we're running these train the trainers, it's fascinating to hear the conversations that happen in the room of people who live and work in the same community who haven't gotten together before to talk about what they want to do together. And of course, to encourage creativity and shared leadership with the primary health network, asking, how can we support you? Our third project, and this is a national project, is about schools. We all know school communities are incredible spaces to open up conversations around death and dying. So for our Dying to Know Day campaign last year, we had a webinar with some school leaders and we were able to form this idea. The Schools Micro Grant Project is a very simple initiative. It's where we invited an expression of interest from anybody as part of a school community to work with Groundswell in order to start something creative around loss and grief with children. And then what we did was we gave them a check for $2,500. Now, the reason why we did that is because we were told by many compassionate community champions that they've got these ideas, but the gatekeeping that happens with the very busy, well-meaning school principals is, where's the funding coming from? So Groundswell said, look, if we gave you a check for a couple of thousand, do you think that would make a difference? And they said, yes. So we had 25 expressions of interest from 25 schools, and we chose 10, and the 10 schools are meeting every 6 weeks and talking about what they're learning. So some of them have spent the money on a Seasons of Growth program. Another school is doing yarning circles with their local First Nations leaders. So it's a really exciting way to work, I guess, upstream, and to work in a creative way. And, you know, we picked a barrier and we tackled it head on, and we just kept it really simple. Our last initiative is one you all know about, I know, Dying to Know Day, our 8th year this year. So look, Dying to Know Day, you know, Bruce and John, you talked about the importance of strategic partnerships. It's an opportunity for Groundswell to partner with organisations to help them join the conversation about death and dying. But of course, it's really owned and led by people in the grassroots communities and the health sector. So this year, the most important conversation you've never had can take you to places you've never been. We used to talk about death, to prepare and plan for a future without us. It provided comfort and security for everyone involved and drew us closer together when we needed it most. The conversation itself was an act of love, bearing witness to a life well lived, and simply having it could open doors to the soul. So we're bringing it back, and you can too. That's our health promotion campaign for this year. Our aim last year in the team was to really shape the health promotion messages to what we call the uninitiated, all the Australians who don't know that they're missing out on having a really critical conversation. And so that was what was behind our thinking and the messaging this year. There's about 20 to 30 events that we're aware of being planned so far, and our focus at Groundswell is to connect with local councils and with workplaces. And also, you know, we're targeting the Gen Xers, so the adult children who have aging parents and young children, the doers, and we're reaching out to them in particular this year. So that is a little bit about a lot. If anything piques anyone's interest and you want to have a yarn, just drop us a line at the team. And how are we going for time? How did I do, Bruce? I'm checking my timer.
Excellent.
I saved a minute.
Right on. Terrific, Jessie. Look, thank you very much for that. That's great. And once again, of course, further details are available on the Groundswell project website as well. I'd like to introduce to you now Professor Summer Owen. Summer is Professor of Palliative Care Research at La Trobe University, but she's also Palliative Care Research Team Leader at the Perrin Institute for Neurological and Translational Science in Perth. And she's going to be presenting on the Compassionate Communities Connectors model of care. It's a community health services partnership in the southwest of Western Australia, where Summer is both researcher and community participant herself. Thanks, Summer.
Thank you, Bruce, for the introduction, and it's really great to be part of this webinar today. So let me just get on and remember to screen share. Can you all see this? Good. Okay, so I'm going to talk about the Connectors project, and I'm really mindful that, you know, Bruce is really, really strict. So, but before we start with the timing, these are the beautiful connectors. But before I start with this, there's a whole research program that actually went before that on bereavement care and support. So you may all be familiar with the public health model for bereavement support, where we showed that the majority of the people with, you know, have got low risk of complicated grief and can be supported really well with family and friends. You got the moderate risk and you got the high risk. Now, this featured also in the latest Palliative Care in COVID-19 of Palliative Care Australia. The UK Alliance for Bereavement Support have used it basically to look at provision for bereaved children and their parents and carers. Ireland, they've looked at it as well, and it's gone into policy, pyramid of adult bereavement care. But what is, and also as Bruce mentioned in one of his slides, we've looked at how the bereaved carers who are looking for people with motor neuron disease, their bereavement experience is different, and a lot more of them are in the moderate risk or the high risk compared to the general population of the bereaved people because of the traumatic nature of the disease. But in all that, the common denominator is that they all said they get most of their support from family, friends. Interestingly, the funeral providers comes third, and that's mainly in the informal. And as you can see with the light blue, this is where they said they're not quite helpful. So not a lot of them said family and friends and funeral providers are not that helpful in providing that. So this is what happens after death, but surely all these people have actually been acting as support for the families before death and leading up to death. So as Palliative Care Australia said in the Productivity Commission report, that we really need to see how we can get more Australians to die the way they really want to die. And only 10% of a person's day is with formal care, and the 90% is really with the informal carers, spouse, caregivers, family and friends. So how can we build the capacity of the community to actually provide more in the 90% of our day? So in the southwest of Western Australia, we started the Southwest, we co-founded the Compassion Communities Network, where every person, every family, every community know what to do when a person is caring, dying or grieving. We were part of the 9 groundbreakers communities around Australia. We're down there in Bunbury, and there was an evaluation done on that. So what are we aiming? So this is again what Bruce mentioned. How do we do partnerships with health services? And the WA Country Health Service have been very interested in this model. And this is what we're trying to develop, implement and evaluate that model of community volunteers. We've also developed an evaluated training program, and we're at the stage of starting to assess the feasibility and acceptability from the 3 target groups, whether the connectors, the health service professionals, and the families that the connectors are looking after. So the primary outcome is increase in social connectedness, and the secondary outcome, decrease in hospital utilization, decrease in caregiver support needs if they have a caregiver, increase in advanced care plannings, or at least the conversations. And are they satisfied with this model of care? And is this something that the WA Country Health Service can embed in their routine practice? So the connectors offer assistance to the person by identifying the additional support and practical support they may require, basically. It could be informal and could be formal. And again, these circles of care are so important here, and this is where the role of the connector, they actually travel across all these circles of care to make things happen. The caring helpers are those who actually come and help with the practical and social support, whether walking the dog, doing shopping, transport, and so on. We've published the protocol on that, and we are pretty much on track, basically following this protocol. We had 28 members really interested. We did 2 training sessions, and at the moment, I'm presenting the work from the first training session. And the training program had, again, all sorts about, what is public health, palliative care, compassion communities, how do you work with a health service, death literacy. As you can see, we've raised the confidence of the connectors quite a bit from where the blue they were to the green. So can't go a lot onto this, but the comments we had, it was great to talk freely about death and like-minded people. The resources were great. Everybody was kind, caring, compassionate. We'd love more training and catch-ups. Great to have access to information, knowledgeable facilitators, end of life and grief, and being a valuable community connector. Resources were amazing. So this is where basically the domains of care, the connectors operate, or the caring helpers. We've developed a community directory, very much similar to the Mendip in the UK. We are evaluating it over a 12-week cycle where the connectors and the caring helpers are, helping families. So far in 10 months, we've had 30 patients and 12 carers consenting to participate, but the consent rate was just 55%, which is quite, I suppose, expected in a palliative care setting. So that's why we've got now, we have started recruiting from chronic complex disease, not necessarily at the palliative, at the end of life care stage. So a lot of reasons for why people declined. Some of them are still doing the treatment and all that stuff. They don't want people to come to their homes, fair enough. We're also approaching it from a community perspective, whereby the communities can, basically the families, refer to this project. The 30 patients, the interesting thing here is that 43% are home alone. This is, quite a lot that have been referred to this service, and 12 carers. So far, 219 hours have been spent by the 7 connectors to connect with the families and find the caring helpers. So what they're doing, sourcing professionals to home visit for wills, they connected with aged care services, equipment access, transport, joining community groups, gardening, social visits, and so on. We have fortnightly Zoom meetings with all the connectors, and we've started the semi-structured telephone interviews with the 3 target groups. So for instance, the patient and carer feedback. Please, can I thank you for the blessing of beautiful Jenny, the connectors. No words can describe the support. I would, and as you can see, really grateful about what the connectors are doing. I can't really read all that stuff. But the interesting, it says, always keeps her promises. A lot of paid carers really don't care, just filling the hours. She goes above and beyond and seems to care. This is one patient with her caring helper. The connectors, helping people in difficult situations. There's a lot of, positives for the connectors for being in this. Most of them have been people who have done this kind of work in the community, but they are part now of a community of care, and they're able to exchange ideas and, feed from each other's basically experience. So basically, fabulous program, would recommend it, should be developed in each town. I was amazed by how many people wanting to help, and not just people who are retired, but people from all ages. The palliative care team so far, they really kind of felt how the families have enjoyed having connectors and benefited from having, really resulting in less visits from them to the homes of people. They found it very easy to implement. Again, they found this in rural areas where we don't have formal service available. This would be a really great service. So how do we connect all the dots? And again, it's back to where the community is at the center. We've got all these services on the right, whereby we'd like them to be more integrated than they are, whether disability, aged care, specialist or generalist palliative care services, primary care, allied health. And on the left, we've got the enablers, and one of them really is the compassionate communities, whereby we enhance people's social networks in a big way. And again, a lot of education and training is needed. Don't forget the not-for-profit organizations who also do a great deal of work, and where these conversations are happening. Conversations are not happening in hospitals or clinics. This is where they are happening in the community and not-for-profit organization. So we really need to bolster them better to have a better public health approach to palliative and end-of-life care. And just to finish all, we are really putting all that together in a statewide forum in WA on the 7th of August, sort of with Dying to Know Day, and activities on the 8th of August, to coincide with Dying to Know Day. So everybody is invited to attend, and that's about it. Bruce?
Wow,
and it's not to be cut off.
Thank you, Summer, and congratulations on finishing an hour's material into 10 minutes. I remind you the slides will be available for those of you who, well, I'm sure, I don't know, I'm fairly good at speed reading and I couldn't keep up, but I'm sure there's a wealth of material there. Thank you, that's terrific. Our next presenter is Charla Mills, who's the CEO of Palliative Care Queensland. Who has been travelling rapidly in all directions at once over the last few days, both in connection with VAD legislation and National Palliative Care Week. And Charla will be presenting on Queensland Compassionate Communities activities and initiatives. Thanks, Charla.
Thank you very much. Can you hear me? Sounds okay. I'm just quickly putting up my presentation now. So can you see that presentation? Yep. Okay. So hi everyone, and thank you very much for having me. I'll probably talk really quickly as well because there's lots to cover, and I know Bruce, with his amazing background there, can I just say that is a real background, I do believe, is on us for timekeeping today. So Queensland Compassionate Communities, just going through what we've been doing up in Queensland. So obviously Palliative Care Queensland is the peak body for palliative care across the state in Queensland, and every other state obviously has a similar organisation. And then there is Palliative Care Australia, which we are all separate to, but we're all members of Palliative Care Australia as well. So each of us operate in our own way. Just to start by acknowledging the First Nations and the traditional custodians of the land of wherever we gather today, and pay respect to elders past, present and emerging, and recognise anyone in this webinar today with Aboriginal and Torres Strait Islander background as well. And also acknowledge any sorry business that is happening over the country at this time as well. So at PCQ, we believe that the way we care for our dying is a significant indicator of the kind of society we are. And we have three main priorities of the organisation, and one of them includes social networks. And this is a key initiative that we have of our organisation. So we say at the beginning of every meeting that we have that our organisational priorities are, and we read them off, and one of them says, have access to supportive social networks at the end phase of life and the choice of quality palliative care. So it's embedded from the very beginning. It's fabulous that everyone's using circles of care today, because that's exactly what I've done with my presentation. I thought, wow, I got the memo right, but it's wonderful. So I don't need to even explain circles of care. But what I thought I'd do is actually talk about what PCQ has been doing in this space in relation to the circles of care. So you can look at the different layers and how we've thought about it in different ways. And I think it's particularly everyone has talked about, and Bruce mentioned it first, about forming strategic partners. And that's something we're really trying to do at PCQ. We've got different layers of activities, but really our partnership has been critical. And that's really where, as a peak body, we can play a key role in both sides, working with services who are our members and other community members, also community groups and other peak bodies that we collaborate with regularly, and just make sure that public health palliative care is on the agenda there too. So we'll start looking at policies and systems. So we integrated public health palliative care into our vision statement back in 2017 and used Alan Kelleher as a quote in this. And this is a vision statement for Palliative Care Queensland. And it really just starts with community, and that's really important for us. And it's a great reflection tool for people to really understand what palliative care is about. We also integrated a focus area. We have 5 strategic focus areas in our strategic plan, and one of them is purely about community. So we added it into our strategic plan for the organisation to ensure that we're reporting on this regularly, we're accountable, and our direction as an organisation includes community as an organisation. And we're just updating our strategic plan now, and we'll be continuing to have community in our strategic plan. We hold an annual series of roundtables every November, December, and one of them is always on public health palliative care. And then we publish the results as key improvement areas based on the results of that roundtable, so that the sector can use those results in different ways. And we do this every year. And so it's also a good opportunity for us to map year on year what's changed in this space and what's relevant to Queenslanders and how that's adapted over time. And obviously there's influencing factors such as changes in the models of public health palliative care, but then by integrating that into strategy and policy in Queensland's a really effective use of having a collective voice in the state. We also, as part of our roundtables, that informs our priorities, which we have an annual advocacy priorities document for the state. And often, because around public health palliative care is included in those conversations, that often comes up as one of the priorities. So for example, the 2021 priorities, which will be launched this week, the third priority is actually, which is written here, work with community through the philosophy of public health palliative care to increase awareness, engagement and partnerships. And then we list off focus areas that came out of that. So our aim is that everyone uses these priorities, from government to services to community groups, and all really works together and focuses on the same thing. And then we can have some collective change. We also do a number of publications and consultation across the state as a peak body, and we ensure that part of those conversations includes community. And so these are some examples of publications that we've done recently. All of them has an element of public health palliative care as some of the recommendations or some of the discussion points that we've had as well. So service delivery. So working with our services, who are mainly our members, one of the biggest things we do here is looking at National Palliative Care Week, which I should say Happy National Palliative Care Week to everyone now, as this is obviously a National Palliative Care Week event, but that's a key thing. So it's enabling services to do community engagement, community awareness, and sharing resources with them there. We also do an annual award ceremony for palliative care in Queensland. And as you can see there, we've circled that we also have a Community Changemaker Award in Queensland. So this is a lovely award where sometimes we don't even know what community members are doing across the state. And through these award programs, people put in a submission or a nomination for someone, and we learn all these wonderful initiatives going across the state. And it enables us to highlight and showcase that Community Changemaker is a part of palliative care as well. We do sector education, and some of those we focus on public health palliative care. So such as an example of today, this is an opportunity that we can showcase public health palliative care during National Palliative Care Week. The next one's looking at community initiatives. So this is a lot around partnerships, and we work with what we call the Compassionate Communities Peaks Network. So we meet monthly with Health Consumers Queensland, COTA Queensland, Carers Queensland, also Queenslanders Living with a Disability Network, ADA, Volunteering Queensland, and we meet regularly with them to look at compassionate communities, how we can talk to our members with the same voice in this space, how they can feed across to us anything that's coming up in relation to serious illness, dying, deaths and grief. And we work collaboratively really well, and we've done a number of projects with each other there. The other activity we've done is up in Townsville. We've done a Townsville area palliative care plan. And part of that, like all palliative care plans, we got the PHN and the Hospital and Health Service to sign off or endorse it. But we also worked with all the local councils. So you can see here that there's 7 local councils in that region. They have all endorsed this palliative care plan, and they all have committed to sitting on a working group for 4 years, meeting monthly to focus on palliative care in their region. So we were very delighted on that, and we have learned so much by working that closely with the councils. It's been wonderful, and I'm really looking forward to the outcomes of that activity. We do awareness campaigns. So this was our Palliative Care Is campaign that we run, just demystifying what palliative care is and trying to explain it in simple languages. The next one's looking at outer networks. So we worked there, we did a compassionate community conversation series across the state, having open conversations with different networks of people around the state and just asking them doing community asset mapping and understanding what they actually currently do, what do they perceive are the gaps, how does it work in their community, and then published a report which we shared with everyone across the state as well, that they can use and hopefully use this as an advocacy piece or a way to approach palliative care in their region with their own services, supports, community, and collaboratively work together. We've developed Pali Learn, which is a public education program for community, and we offer the basic program for, I think it's $5 or $10 a 1 hour online session. So we keep it really cheap and available for everyone. Often we get these sponsored by different community groups, and it enables us to have a standardized support network for people in this space to learn basic public education in this space. And we do intensive education, and most famous one of this is Last Aid. We've brought Last Aid to Australia, the international training program. So just like First Aid, there's Last Aid, and it's a really simple 4-hour training program, and it's a fabulous initiative, and the language is fabulous. Like Last Aid is much easier for people to understand, a little bit like compassionate community. They get it, and often they find a barrier with palliative care, but language is important when promoting these discussions as well. In a network. So we do kitchen table discussions in partnership with Health Consumers Queensland, and these are consumer hosted conversations with their community, and we give them a series of questions. They then ask them to their local community in kitchen table or discussions around a local park, wherever they want to be, and they feed those responses back to us. And for me, I've really found this is a great way to get to another layer of consumers. Not often the professional consumers, as some people might say. This is getting to the real community groups. And they are so often, they're really proud of the fact that they got their voice into documents, that we publish their quotes and things like that. And it's a great way to show that they can be advocates for this space as well. And they can inform choices across Queensland. We do a little project with Brisbane South Primary Health Network called Pali Chat, and this is about promoting healthy dying conversations. We have a series of different ways that we do that through networking, training or education, and little group support networks as well. So it's a lovely little program based on the Mendip model, which I heard Jessie mention before. So we're all inspired by that model and looking at different ways we can adapt that in Australia. And the person and the carer. So we give resources, you know, like we all do, but good resources for community is really important. We do what is compassionate communities, explaining different supports that people can have as well in the space. And we also adapted these for COVID. And we worked in the COVID time with people in hospital quarantine that were traveling to Queensland and were stuck in their hotel room for a few weeks. And often they're here to visit someone that was dying. So we realized that they didn't have that support network around them. So we adapted these to provide some local networks and local organisations that could provide them that support during this time. And finally, the big thing that we've done in this space, which most people know about, is Ambulance Wish Queensland. So this program, we have a decommissioned ambulance, and we partner with specialist palliative care, volunteers, the ambulance service, and we basically deliver last wishes and create memories forever for people. It's a lovely program that has basically reframed palliative care for us in the public. So often people think of palliative care as dying, pain, morphine, and really this has changed that face to being about positive stories, memories, like going to somewhere where you, which means a lot to your life. And people really engage with it. And I guess we really thought of this as a plug-in to social aspects of palliative care. But what we didn't realise would be the community engagement and awareness raising opportunity of this. So when we launched it, we actually had it went viral, and we had a social media reach of 155 million online, and newspaper articles all over the world and through print and online media and in multiple languages around the world. And that was something so simple as a little lady, Betty, who wanted a passion fruit ice cream, and how everyone came together to support her. So for us, that is a great example of a compassionate community. And we really say, this is for people that have mobility needs. Everyone could provide wishes to people in different ways. And that's really what a compassionate community can do. So I'll just finish now with where I started and read out the vision statement. So imagine if communities really cared about their members' health and social well-being. Imagine if that care extended to the dying, death, and loss experienced by everyone in those communities. Imagine how your community can support you to prepare for your own death. What would that community look like? Thank you. Back to you, Bruce.
Terrific. Thank you, Charlotte. A wonderful set of initiatives and resources for you lucky people in Queensland. And but I'm sure in actual fact, a lot of them could be adapted by us Mexicans south of the border, or even west of the border as well. So thank you very much indeed for that overview. It's terrific. Last of our presenters is Dr. Kerry Noonan, who's director of the Death Literacy Institute and living with the mice out in Dubbo, I understand. But she's been a mover and shaker both nationally and internationally in this public health palliative care international public health palliative care scene for a long time. And thank you, Kerry, and welcome.
Thank you, Bruce. It's really fab to be here, and it's really cool to be last, going last after all those amazing initiatives. And this is really, you know, one of the first times that I'm talking about the Institute publicly. So it's really, we've got the smallest amount of input and output at the moment, but it's exciting to be able to go after all of that inspiration. So let me share my screen and make sure I know what I'm doing, hopefully. Is that working? Yes. Okay, so before, okay. Good. Before I begin, I do want to acknowledge the Wiradjuri people, who are the traditional custodians of the land in Dubbo that I'm here on today, and pay my respect to elders past, present and emerging, and to extend that respect to other Aboriginal people who may be present here today. As I said, I'm really delighted to, I'm having some technical problems, sorry, just give me 1 second. I'm really delighted to be talking about our work and really interested to be participating in this kind of broader conversation. the Death Literacy Institute, I'll talk a little bit about why we set up, but for many of you, you know that, so I founded the Groundswell project and was involved in Dying to Know Day for, you know, a good decade. And that plus the work that we did at Western Sydney University, the research work on compassionate communities and social networks and death literacy, has really been, I guess, the catalyst, and the you know, those two things have really kind of led to the development of the Institute. And we've got some broad goals, and some of hopefully, obviously, but hopefully I can talk you through some of the work that we're doing, and I'll give you a couple of examples. But our goal is to work across sectors and institutions with people, places and organisations. And we focus particularly on death literacy and grief literacy, because that's really, you know, for us, it's really about those four things: skills, experience, action and knowledge that create death literacy. And we're focused particularly at the moment on training and education, but also supporting other organisations. And that's probably at the moment one of our kind of key goals, is supporting other organisations to do the research work and evaluation work that they're doing around the work, around their own compassionate communities work. So we work with people, that's anyone in the dying, death, grief and loss space. We work with organisations, so we started working with health organisations and peak bodies, as well as kind of focusing on teams and communities. So teams who may want to work on their death literacy, for example, or communities who are interested in developing compassionate communities work and be able to kind of bring together some of the work that's happening and be inspired by that from other projects happening in Australia. And we've got, I guess, a broader interest in, in death literacy in society, and how the death system impacts on the way that we think about loss, grief, death and dying. And for us, that's really kind of a broader change piece, and working with other organisations to keep kind of coming back to thinking about what are the levers for change in the death system that are going to enable some of the work that we're all doing towards innovative practice. So kind of three ways we're doing that at the moment. I just wanted to talk about, so we're doing some research. We're still learning about the role that the Death Literacy Index plays in the work that we all do. And there's a lot of work, cross-cultural work, as well as international work happening. And that's really important because the Death Literacy Index is actually a really very new kind of way of looking at death literacy. So we've been involved in looking at using the Death Literacy Index as a way to understand what's happening for communities. And that really goes, I guess, with the training aspect of what we do. So we've been working with one peak body, for example, to develop their training and education around death literacy. They've got a strategic plan. Their strategic plan is about developing death literacy. They brought us in to kind of do some work looking at their whole population, all of their members, all of the people they work with, looking at their death literacy, then implementing some training, and then seeing how death literacy changes as part of training that we co-design with them around death literacy. And that's really for us kind of one of the most exciting things I think that we can do in terms of working around, working with organisations. I think the other thing that we seem to be doing in the space so far, and we only, started up at the end of last year, is offering a kind of an evaluation space. So there are lots of organisations that don't necessarily want to do research with universities, but they want to find a way to evaluate their work. Smiling. They may not want to do all of that. They may not want to get into the kind of whole university side of things, but they want some advice and some support around evaluating what they do and how they do it. Because, I think for all of us working in this space, the way that we talk about our outcomes and talk about our impact is actually getting more and more important in this space. So they're kind of three different aspects of the work that we've been doing so far. And the link to, so one of the questions for today was, what's your link to public health palliative care? And so for us, it's really across the Ottawa Charter. So it's sometimes it'll be supporting other organisations who are doing this work, but certainly we want to have a broader policy impact. We're interested in the end of life space and how the end of life space is building together to create change, and that is broader often than palliative care and involves other aspects of the death system. And we want to look also at how people develop the skills they need to do the work that they do. So, so when we think about impact, we're thinking upstream interventions for downstream impact. So supporting other compassionate communities or other organisations to do compassionate communities and death and grief literacy work, and really supporting the growth of really strong research and strong evaluation and communication around this work in the sector. So that's me today. So thank you. And if you've got any questions, I welcome any questions about the work that we're doing, but also look forward to continuing to work with some of you in the future.
Terrific, Kerry. Thank you very much indeed for that. And it's nice to have one of the newest initiatives turning up on the conversation as well. We turn now to questions, except there is nothing on the Q&A. So I'm not entirely sure whether that's because we just simply blitzed you to such a degree that you sort of, I don't know, struck dumb or whatever the typographic equivalent is. But while we wait for a moment or so, perhaps for some questions to emerge, let me again thank all the presenters. I think one of the things that's been demonstrated is the sheer diversity and possibility. That one of the things that a public health approach is not a series of strategies, but a way of looking at the world and a way of thinking about issues. And while there might be some common frameworks and common models, there's an infinite array of possibilities that emerge when you look at the community around you and the people around you and ask, what sort of sense can we make out of what's going on here? So it's a ground up discovery process, which I think is really interesting and refreshing and encouraging. I suppose the other thing I should say is to acknowledge the support of Palliative Care Australia in supporting this event as part of National Palliative Care Week. Palliative Care Australia, as Charles noted, is the umbrella of the peak body for Australian palliative care services and a range of membership. And their work in liaison with government in particular, is, as well as liaison with state bodies, is a really important one. I will continue to put a suspicious eye toward the Q&A, but unless there has been some digital malfunction and there are questions disappearing into the ether, there are none there left there. May I also remind you, though, that the PowerPoint slides will be available on I think on an exchange basis is the way I interpret it here, that there will be an evaluation form emailed to you after the webinar. And I suspect it's probably almost an exchange process that if you fill in the evaluation form, you get the slides. Is it as crass as that, Charlotte? Sorry, no, I shouldn't put it in that way, should I? But I mean, a mutual exchange and mutual support will be for that. Again, we see some comments coming through on the chat, but also on the Q&A. Wonderful. This is terrific. Okay, so we've got two questions and a couple of minutes at least to run with that. So first of them is from Rebecca, and it's to Summer. I don't know, can you see these, Summer, or can you?
Yes, I've just read them. So
Okay.
what is the protocol? I answer them now?
Please, yes, go for it. It'd be great.
Yeah, so thanks for the question, Rebecca. We have looked at what kind of support is meaningful to these people, and particularly what they're getting from family and friends. And it's more of that, we have an article, and I could send it to you. It's on that personal attachment that meant to them, and also on the tangible support that they get from them, whether, you know, they're cooking a meal for them or taking their kids to school. That meant a lot to them. And this is where they got from what they got from family and friends. Funeral providers, they were there at the right time in their acute grief. And I think this is why they, you know, I mean, Bruce and I have discussed this quite a bit in terms of why have they come up so high, but they are at a very critical time for these people. They take the load off them in terms of preparation, you know, all the logistics basically. And, you know, they are very, well, in general, they're very professional in what they do. They're compassionate, and they really play a big role in that space. So I don't know, do you want to add anything, Bruce, that on particularly, because
no, I think it's really about the timeliness of an intervention, isn't it? And people who come are able to provide some sort of frame or some sort of appropriate response, which enables people to somehow gather up or shift or understand their experience a bit more, is really important. But the timeliness of it is what the funeral directors illustrate. Yeah.
Can I add to
that's
that?
great.
Can I add to that too, Bruce, if that's okay? One of the things that we've done recently is we've just started an evaluation with a funeral director. So Samara and I have talked about this too, and I think one of the things we're interested in understanding is we've used some of the same measures that Samara uses in her research, but kind of dug in a little bit more around what funeral directors are offering and what they offer and how they offer it as part of the evaluation process. So that's, I think that's going to be something that we see more of because of the work, that public health work that Samara's done. One of the things we're starting to stretch out into is like digging a little deeper into like the whys and the whats, like what Rebecca's asking.
Yeah, thank you. And there's one from Karen Bolger, and Karen is asking a question about the difference between caring helpers or connectors and palliative care volunteers. And perhaps if I could put it in a bit of a nutshell, volunteers, in a very real sense, tend to extend the work of the palliative care service, whereas the connectors are actually about connecting into the community. So that while volunteers come in to amplify, as it were, the work, the support that's being provided by the service, the community connectors are about mobilizing the person's existing network and perhaps adding to it, not necessarily plugging holes themselves in any particular way. In fact, preferably not doing that, but rather making the connections into the resources that are there in the community. So that's my attempted summary. Others in that space, what about that?
And can I mention from our experience in WA, and because we have 43% so far who are home alone, they really only want to connect with the connectors because they are home alone. They don't want to have more people come into their house. And it seems that, they think the connector really need to do everything for them. And there's quite a resistance on bringing in caring helpers. Then you've got another section of these patients who are saying, well, we only want the doers then. Why can't the caring helpers come in? Why do we need the connectors then? So the project has thrown in a lot of interesting sort of, just depends on the dynamics of each family. And because there is a lot of social isolation, what those home alones are really enjoying the social visits from the connectors, and they want to hold on to this. So it'd be very interesting how we write up about all that. Palliative care volunteers, anyway, I'm talking from the experience of my area. They are really basically, they follow the kind of the health system, boundaries and guidelines. while the connectors basically, you know, can connect as they do in general in their own daily life, you know. So they can work well together as well, you know, in a like a model of care once, you know, we can, but they're not there, for instance, when respite is needed. So what the health service is telling us, if a family needs respite, the only way is to take the patient to an aged care facility. While now with the connectors, you know, they're able to basically bring all these caring helpers so that that person, the carer, can have respite without having to move the patient to an aged care facility. So I'm not sure that can happen with palliative care volunteers. So this is just one of the nuances that we are finding, you know, in the way it's operating here in WA.
Yeah, so Karen, that's an astute observation, and it's a work in progress, I guess you could say as well. Yeah.
Bruce, I might just jump in. Is that okay for one quick response too?
Well, just to say that Kim asks the question, are all palliative care patients in the community listened to with their wishes? Ooh. Sorry, did I cut across it? Jesse, you were going to ask, respond to
I was just going to add one comment to the community connectors, just very briefly.
Yeah.
I think, you know, what I've noticed in the approach that we've taken is the importance of the way in which relationships are introduced, such that there's reciprocal relationships and reciprocal friendships. And that for me is a key demarcator between the two. Yeah,
mutuality. Yep, terrific. Kim asks, are all palliative care patients in the community listened to with their wishes? Well, the answer is sometimes.
So I'm happy to jump in on that one if you want.
Please do, that'd be good. Yeah,
this is the sort of thing the peak body gets asked all the time. I think really, you know, one thing for me is around, well, are they even asked what matters most? What are your wishes? You know, if you look at advanced care planning and things like this, we often ask what you don't want rather than what you do want. And this is about reframing, like everyone's talked about. So I think first we need to know what their wishes are, and then we need to create this network of support around them, which is a combination of partnership between health and social and community that can help them fulfill those wishes. And then it's about ensuring that's available to them and their family. A little example of that is our ambulance wish program. So, you know, like I'm a nurse background. And so when we developed this, we were like, we will give them what they need for a wish. And then we realized, actually, no, we will bring the transport side of it, the coordination side, but the families do the most amazing smorgasbord of food. They love the actual organising the party side of it. If we get the care part right, they do the other side to make it a memory, which they would do for their families anyway. You know, so a lot of this is about working with, not to, which everyone's mentioned. And I think particularly in that question around, you know, are their wishes fulfilled? Well, do we ask them? And then do we work with them to fulfill the wishes? Because it's not the role of the sector to fulfill people's wishes. It's our role to work with the family and the multiple circles around them of the circles of care to fulfill wishes. So that would be my answer.
Yeah, thanks for that, Sharla. There's, I think, probably will need to be a final question up here. And Anne asks, are connectors similar to navigators? And Jessie volunteers.
Yes, with a caveat. So the connectors that we're working with is, you know, we were trained in this model called signposting, and signposting is kind of the citizen version of referral. So it is not the connector's job necessarily to help people navigate just, you know, services in the system. It's rather about saying, I'm going to signpost you to the different clubs and services and people and places that I think could benefit you at this point in time in your life. There's another role that accompanies the connector role, which is called the health connector model, and that is more about sort of navigation, I would say. So there's a bit of nuance around the language.
Yeah, thanks, Jude. Yeah, so similar skills, but maybe different audiences and conversation partners in that as well. Well, we come to an end, I think, according to the directives or the contract for the webinar. Thank you again for your participation. We really appreciate that. I'm sure that all of us will be happy to receive any further sort of comments or reflections, either through the evaluation form or even by direct email. I think you'll be able to find any of us either emails on the PowerPoint slides, or a simple Google search, I think, will probably locate most of us. But thank you to presenters, to John and to Jesse and to Summer and Shyla and Kerry. It's wonderful to catch up on the national network in this particular way and to be refreshed and reminded of your work. And every good wish to all of you as you continue to reflect on the material that you've heard and the way in which it might actually speak to your own particular situation and context. And if you come up with some bright ideas, do let us know. Thank you very much indeed, and farewell.